topic that we are going to discuss, guys, in this lecture, lens, is probably one of the easiest. It is easiest because, number one, I expect that all the students who are there would have studied it in their respective MBBS years. Lens or cataract is one of the most commonly asked topics if you are a third year student. They ask you about the surgeries, they ask you about cataract, the main disease, and they ask you a lot of other simple questions. If you are a pre-PG student, because you have already studied it, you have wasted almost half of your third year as far as ophthalmology is concerned on lens and probably the other half on cornea. You should find it easy. Secondly, it is easy because it does not have any concepts per se. It is merely a fact-based topic. So facts can be learnt. You don't need to put your brain to it. That's all I'm trying to say. Though, if you ask me in another way, it is actually more time-taking because you need to revise it more often compared to a topic like neuro-ophthalmology or squint, where you can frame your concept, guys. This becomes a more of a topic which takes a lot of revisions because it will have thousands of little facts which you may or may not be able to remember till the time you need them, right? So I will begin with the chapter lens by discussing some very basic simple points about it. We will be basically dividing into groups. First of all, we will be discussing the basic anatomy, biochemistry. Then we will be moving on to the main disease, that will be the cataract. And lastly, we will be doing some other topics like ectopia, lentis, lenticonus, and small pathology conditions. Right, guys? So let's start with some basic points in lens. All of us should know the answer to these questions. When I am writing them, when I am teaching them, try to answer yourself these answers before I say the answer, right? So, lens, point number one, very simple point. What is the color of lens? I said they will be easy, I know. So, you already know, everybody. Lens is transparent. The lens has to be transparent because it needs the light to travel cross the lens and travel to the retina. Yes? If it is transparent, then my second question also becomes redundantly. What is the blood supply? The blood supply will be avascular. As I have pointed out before, guys, in cornea also, that cornea is transparent and thus it needs to be avascular. Similarly, lens is transparent and that is why it needs to be avascular. Yes? So, simple correlation, guys. Third point. What is the nerve supply of lens? Does lens have any nerve supply? Third, fourth, fifth, sixth, any cranial nerve? No, guys. Very good. So, there is no innervation. There is no nerve supply. Absolutely. Number 4. Again, a simple question, guys. What is the shape of lens? What is the shape of lens? We already know it. If you have seen the basic anatomy lecture, guys, we have seen the structure of lens in accommodation. So this is what is the shape of the lens. What will you call the shape, everybody? The anterior surface is also convex. The posterior surface is also convex. So we simply call this shape as biconvex. Both the surfaces, everybody, are convex, biconvex. Now, if you have noted previously, if not, then focus here. The anterior surface is always less convex, or I can say slightly flatter in comparison to the posterior surface, which is always more convex, or more curved, whichever way you want to say. Okay? So it is relative in comparison to each other. Now, if I want to ask you about the anterior surface, what is the radius of curvature? Just simple basic common sense comes here, everybody. The radius of curvature of the anterior surface, because it is flat, should be greater. It is 10 mm. And the radius of curvature of the posterior surface, because it is more curved, the radius of curvature will become smaller. This is 6 mm. Okay? So with the shape, we have been able to answer questions about the anterior surface and posterior surface also. Looking at this diagram only, If I draw a line here, guys, this is the anterior surface, in front of it and behind this line is the posterior surface. So what is this line known as? This is an imaginary line which is basically dividing the lens into anterior and posterior. So this is your equator of lens. Okay, so this is called the equator of the lens. The equatorial diameter is around 10 mm. The equatorial diameter is around 10 mm. It can vary from 9 to 10, guys. I'm just taking around 10 mm. Am I clear? No confusion? Then, this is which diameter, everybody? This is which diameter? So this is your obviously anteroposterior diameter. So I hope you understand that there can be two diameters. One is anteroposterior and one is equatorial. No confusion about this, everybody? Yes? Easy question, simple questions, right? Now, next simple point, next simple question, everybody. Point number 5, if I am writing. What is the position or site of lens? That means where is the lens present in my eye? Where is the lens present in my eye? That's what I'm asking you. All of us know this answer. I'm again drawing the cut section that we must be used to seeing. In front of the lens, this is the anterior segment. Behind the lens is the posterior segment. Yes? So where is the lens present? Can I say lens is present between anterior segment and posterior segment? Yes, I am not wrong. But what is this space known as, everybody? So this space where the lens is present, this space gets a name, and that name, everybody, is called as patellar fossa. That name is called as patellar fossa. Okay? Done? Now. But please don't confuse it with the patella of your knee, everybody. I am not saying that your lens is in your knee, right? दिमाग घुटनों में होता है, आंख घुटनों में नहीं होती. Number 6. Number 6 point, everybody. Very simple question. What is the refractive power of lens? What is the refractive power of lens? Lens has a power. Why does lens have a power, everybody? I'll be using the diagram at the top only to explain you this. Lens has a power because all the light rays coming inside the eye need to be converged onto a single point at the retina. So the lens has a converging power. Converging power is denoted by the sign plus, first of all, everybody. Converging power, convex power. Lens is a convex structure. So plus 16 diopter to plus 19 diopter. Plus 16 diopter to plus 19 diopter. Refractive power of lens. Point number 7. What is the refractive index of lens? Refractive index of lens. See, every structure has to have a refractive index. Air has a refractive index of 1. Yes? So every refractive index is compared to air, whether more or less. So what is the refractive index of the lens, guys? Again, this is a simple piece of information which I hope a lot of you know. A lot of you are saying answers also. Yes, I know that. But to be accurate, I divide the lens into two parts. The central part and the peripheral part. The central part has a refractive index of 1.406, whereas the peripheral part of the lens has a refractive index of 1.386. Okay? So, depending on the part of the lens, we can say the refractive index is different. Usually, in a lot of places, you will find the answer as 1.39. So, if we just round off 1.386 to the higher number, we get 1.39, and that is what is commonly used as an answer. Though I don't think this kind of a question as far as MCQ will be asked to you, what is the refractive index of the lens? So you will never be in a position of doubt to be able to answer whether 1.39 or whether 1.406, something like that. Okay. Now, there is an MCQ which can be asked to you guys. The MCQ which will be asked to you will be, which part of the eye has maximum refractive index? Which part of the eye has maximum refractive index? So please remember, center of lens that we have just now mentioned 1.406, or if we round off 1.41, this is the structure with the highest refractive index in the eye. Cornea, aqueous, vitreous, everything else has a lower refractive index than this. Okay. So the highest refractive index that we have studied is the center of the lens, that is 1.406. Now, continuing in this line of easy questions. Now the next point in the series of these easy points is, lens develops from which part? So the answer is simple. Lens develops from, all of us know that, surface ectoderm. Yes, as we may remember, this is the only structure intraocular inside the eye which develops from the surface ectoderm. Apart from that, all these structures are extraocular structures, or the outermost layers which develop from the surface ectoderm. Right guys? Done? Now, continuing in this format of questions, point number 9 can be explained to you with the help of this diagram. Weigerd's ligament. That is what we want to discuss here. Weigerd's ligament. So what is Weigerd's ligament, guys? As we should be able to see in the image, the posterior surface of the lens, everybody, the posterior surface of the lens is actually touching, or I can say attached to the anterior surface of vitreous. Everybody, this is vitreous. This is lens. Yes. So the posterior surface of the lens, this surface, everybody, is attached to the anterior surface of the vitreous in these areas, as is denoted by the red lines here, everybody. So these areas where the lens posterior surface and the vitreous anterior surface are attached, it is called as Weigerd's ligament. Okay, everybody. So what is Weigerd's ligament, everybody? Attachment between posterior surface of lens and anterior face of vitreous, and anterior face of vitreous. Now, the next structure that we see here marked is Berger's space. Due to the shape of the vitreous and due to the shape of the lens, there is a small potential space, everybody, which I am marking with green dots now, which is left between the lens and the vitreous, and this space is called as Berger's space, or I can call it retrolental space. Retrolental space. See, there are two words, retrolental. If you know the English, it is explanatory. Retro means behind, lental means lens. So Berger's space is a space behind the lens, retrolental space. Yes? Now, the next structure that we see marked in this image is Cloquet canal. Okay, everybody? T is silent here, everybody. Cloquet canal. Now, what is this, everybody? If we see this whole space, everybody, you see a dark gray line in the diagram. This is a potential space for hyaloid artery to supply lens during embryogenesis. A potential space for hyaloid artery to supply the lens during embryogenesis. Now everybody, we know that lens is avascular when it comes to an adult lens, or when we are born our lens is avascular. But during embryogenesis, during development, lens also needs some nutrition, and that nutrition is given to the lens by an artery which comes from the posterior part of the eyeball, travels within this potential space, that is our Klockowitz canal, and supplies the posterior surface of the lens. By around 8 months of gestation, everybody, this Klockowitz canal and the hyaloid artery will disappear. Yes? So that is why we say it is a potential space only during embryogenesis. It should get absorbed by 8 months of age, 8 months of gestation rather. But what if it does not? Let's see, everybody. So Klockowitz canal and hyaloid artery disappear by 8 months of gestation. But if they persist, they lead to, if they persist, that means if they don't disappear, if they are not absorbed completely, they can lead to any of the two congenital abnormalities. The first congenital abnormality is known as Mittendorf dots, and the second abnormality is called as Bergmeister's papilla. Mittendorf dot and Bergmeister's papilla. Mittendorf dot can be defined as remnant of hyaloid artery on the posterior surface of lens, and Bergmeister's papilla remnant at the optic disc. I hope it is very clear. The hyaloid artery was traveling from the optic disc up to the posterior surface of lens. Yes? So we are saying the remnants can remain at both the places. If this is my hyaloid artery, everybody, the remnant can remain at the anterior portion. The anterior portion of the hyaloid artery supplying the posterior surface of lens, Mittendorf dot. Or the remnant can remain here, everybody, at the posterior point of hyaloid artery. That is the optic disc, Bergmeister's papilla. So two ends of the artery, one end, second end, Mittendorf dot, Bergmeister's papilla. So that's a little bit about your Wiegert's ligament, Berger's space, Klockowitz canal, and the remnants, that is Mittendorf dots and Bergmeister's papilla. I hope all of us are very clear about these concepts. Nothing difficult, everybody, just simple points about basic anatomy of the lens. To complete the anatomy of the lens, what we'll like to further discuss is the layers, or I can say the parts of lens. Okay, so basically the structure. Yes? Now, when we divide the lens into structures, we can divide it into 4 parts, as can be seen on the image on the screen, guys. Let's start from the anterior to the posterior side, like always. So all of us can understand that this is the anterior surface and this is the posterior surface by the curvature, that the posterior surface is slightly more curved. Yes? Now, if we see the anterior most layer, or I can say the outermost layer, is this black line that is continuing, but this line is anteriorly as well as posteriorly present. So I can basically say that the outermost layer is continuous around the lens 360 degree, and it is called the capsule. It is called the capsule. Okay, everybody? So what is the capsule? Capsule is a basement membrane. Yes? What is the function of the capsule? Blah, blah. Let's discuss. So number 1, the outermost layer of the lens is capsule. Okay? Now, certain points about capsule, everybody. What we should know is that capsule is the thickest basement membrane in the body. This is an anatomy question also, guys, that which of the following forms the thickest basement membrane in the body. So the capsule of the lens is the thickest basement membrane in the body. If it is a basement membrane, it should contain biochemistry type 4 collagen. Type 4 collagen. Now, if I go back to the image, you will be able to see that the thickness of the basement membrane or the capsule is not constant. Somewhere it is thin. Everybody here in this part, you will be able to see that the capsule is very thin. As you can see here, everybody in this part, it is thin. But at other places, like here, everybody, it is thick. So obviously there are two questions which form here, everybody. Where is the capsule thinnest and where is the capsule thickest? As can be clearly seen, in this area, the capsule is thinnest. And this area is known as posterior pole. The center of the posterior surface, posterior pole. So if you consider your lens to be Earth, everybody, Earth has an anterior pole and a posterior, If you consider your lens to be an Earth, everybody, just like Earth has two poles, North Pole and South Pole. Similarly, we can say that lens has two poles, anterior pole and posterior pole. So at posterior pole, the center of the posterior surface, it is the thinnest, whereas it is thickest in this area. What is this area called as? It is behind the equator. Yes. So posterior to the equator, pre-equatorial zone. Posterior pre-equatorial zone. Am I clear to everybody? So thinnest and thickest capsule. Thinnest at posterior pole. Thickest at posterior pre-equatorial zone. Okay. Simple facts about the capsule of the lens, outermost layer. Now, what is the second part or the second layer of the lens? The second part or the second layer of the lens, as can be seen clearly in the image again, is this single cell layer, everybody, this pink colored layer, everybody. A layer which is formed by a single layer of cuboidal cells. This is your epithelium. Now, the important point to note about the epithelium is that the epithelium is present only anteriorly or at the equator. If we see carefully, there is no epithelium which is present posteriorly. Yes, posteriorly no epithelium is present, and that is why we specifically say that the second layer is, everybody, not epithelium but only anterior epithelium. So capsule outermost layer was complete layer, but anterior epithelium or the second layer is an incomplete layer, present only anteriorly. Now, the epithelium can be said to have two cells, A cells which are present anteriorly or E cells which are present at the equator. E cells are important because they can form new lens fibers. They are actively dividing cells. So they have the capability of performing mitosis. Okay. A cells, E cells. E cells at the equator, mitosis. Mitosis, division. Division leads to formation of new lens fibers. Am I absolutely clear? So layer number 2, everybody, anterior epithelium. Anterior epithelium can, as just discussed, have two cells, A cells or E cells. The function of A cells is metabolism. The function of A cells is metabolism, but E cells form new lens fibers as they are capable of mitosis. So E cells form new lens fibers. Okay. Also, what I mentioned, you should remember that posterior epithelium is absent. Posterior epithelium is absent. But why is it absent? Why is it absent? Posterior epithelium is absent as during embryogenesis, posterior epithelial cells elongate to form primary lens fibers. So actually posterior epithelium was present during embryogenesis when the lens structure first started to form. But as part of development of the lens, the posterior epithelial cells elongated and then they converted to lens fibers, the primary lens fibers. That means the lens fibers which are formed first in the lens, everybody. And that is why in a structure of lens that we see in a child or in an adult lens, everybody, we see that the posterior epithelium is absolutely not visible or absolutely absent. Am I clear about the second layer, everybody? So the second layer is anterior epithelium, A cell, E cell. Done? Now, third layer, everybody. The third layer, as all of you will be able to see this white area, everybody. So this white area is your third layer. And this white area, everybody, throughout 360 degree, again a complete layer, is called as your cortex. Similarly, if we see at the fourth layer, everybody, this central area, everybody, yellow colored area, everybody, this is the fourth part or the fourth layer of the lens, and that is called the nucleus. Okay. Now, cortex and nucleus. What is the constituent of both of these? Cortex and nucleus both contain fibers of the lens. All the fibers that we are talking about, new fibers will form, primary fibers, blah, blah, blah. All of them are present in the cortex as well as the nucleus. So, layer number 3, everybody, is cortex. Layer number 4 is nucleus. Both contain lens fibers. Both of these structures contain lens fibers. Now, if you carefully saw the image, you would have noticed that the nucleus in the center is actually been divided into 4 parts. Yes. Now, why is it divided into 4 parts, everybody? It has been divided into 4 parts because the nucleus keeps on forming, and based on the time when it is formed or based on the period when it is formed, it gets a different name. So first of all, I am an embryo, guys. Yes. When I am an embryo, the nucleus which forms gets the name embryonic nucleus in the center. Then I become a fetus after implantation. So the nucleus which forms when I am a fetus gets the second zone, that is the fetal nucleus. Then we are born, everybody. When we are born, we are called infants. So the third zone is called infantile nucleus. Then we grow into adults. So the fourth zone, the outermost zone, is called as adult nucleus. I hope we are pretty clear about this, everybody. Yes. So there are 4 parts or 4 zones of the nucleus: embryonic, fetal, infantile, and adult. No confusion about this? So what is formed first, everybody? Embryonic. That is why it is in the center. Then covering this will be fetal. Covering this will be infantile, and covering that on the outermost will be your adult part of the nucleus. Okay. So my nucleus has 4 zones as described just now. E, F, I, A. E for embryonic nucleus. For you to remember, I am writing in the center. Then the second zone outside it, fetal nucleus. Third zone, infantile nucleus. And fourth zone, adult nucleus. The outermost part of the nucleus, adult nucleus. Okay? No confusion about this? Now, embryonic nucleus is said to be the primary lens fibers. All the other are said to be secondary lens fibers. So if you can do mathematics, 1 + 1 is equal to 2, you understand that primary lens fibers are formed by posterior epithelial cells. So that is why I can say that basically the embryonic part of the nucleus is being formed by elongation of the posterior epithelial cells. Yes or no? Yes? Now if I ask you a simple English common sense question, everybody, the examiner will ask you which part of the lens contains the oldest lens fibers. So what will you say? Oldest lens fibers means the fibers which were formed earliest. Earliest means primary lens fibers. So I hope the answer is easy, that embryonic nucleus contains the oldest lens fibers. Okay, everybody? No confusion. But what contains the youngest lens fibers? What contains the youngest lens fibers? Youngest lens fibers, are they present in adult nucleus? No. So the youngest lens fibers will be seen in outer cortex. The youngest lens fibers will be seen in outer cortex. Why, everybody? Why, everybody? Again, try to understand. The new lens fibers are being formed by division of epithelial cells. What is the nearest area to epithelial cells, everybody? This area. This area means the outer part of the cortex. So the youngest lens fibers, that means the newest fibers that are being formed, are actually being present in the outer cortex. Am I absolutely clear here, everybody? Yes. So just simple fundamental, everybody. What is the structure of the lens? 4 layers, as you can see. Outermost layer cortex, second layer anterior epithelium. Just a simple fundamental, everybody. There are 4 layers of the lens, everybody. Outermost layer capsule, second layer anterior epithelium, third layer cortex, and in the center, the 4 zones of the nucleus. Done, guys? And that's it about the layers or the parts of the lens. Now, to complete our anatomy of the lens, everybody, I'll just discuss the last point, everybody. That is the sutures in lens. Sutures in lens. Okay? Now, sutures in lens are formed during fetal period. They are formed during fetal period. I am telling you they are formed during fetal period. Sutures? What do you mean by sutures? Aren't sutures those surgical sutures that we use to tie the wounds? So sutures, why are they formed in the fetal period? What do I mean to say? What am I talking about? So sutures, guys, see again, my clue is they are formed in the fetal period. So they are an anatomical structure. I am not talking about the sutures. Yes, I am not talking about the dhagas that you need to tie the wounds, everybody. I am talking about the sutures like they are in the skull, everybody. Yes or no? So sutures basically mean joints. Yes? So there are 2 joints, or there are 2 sutures in lens, and those sutures are formed during the fetal period. The sutures are called as anterior suture and posterior suture. Anterior suture and posterior suture. Okay? The anterior suture is classically Y-shaped. This is the question that they will ask you. What is the shape of the anterior suture? So that is Y-shaped. Whereas the posterior suture has this shape. What will you call this shape, guys? What will you call this shape? Are you saying lambda? I know that some of you are saying lambda shape. But please understand, lambda is like this. I have drawn this. There is a basic difference. We do not call it lambda shape. We call it inverted Y-shaped. Am I clear, everybody? So please don't confuse the shape with lambda. Lambda has a subtle difference, everybody, and that is why it is simply called as inverted Y-shaped. Done, everybody? So only 3 questions can be asked from sutures in lens, everybody. Number 1, where it is formed in the fetal period, so in the fetal nucleus. Number 2, what is the shape of the anterior suture, and number 3, what is the shape of the posterior suture. And that's all about my anatomy of the lens, guys. I hope you are pretty clear about this. Just some 10 or 11 points. Some difficult, no, I won't say. Some points which you probably may not have known, but all easy points, fact-based questions. Lens is a fact-based chapter at last. That's what you need to remember, guys. Okay. Now, after we have finished the anatomy of the lens, the next topic that I'll like to start with all of you is proteins in lens. Proteins in lens. Okay. Now, proteins in lens can be divided into two major groups: water soluble, water insoluble. Water soluble proteins, water insoluble proteins. Water insoluble proteins can further be divided into two groups: urea soluble or urea insoluble. Water soluble proteins are known as crystallins. That is why, if you remember everybody, we say that a phakic lens is known as normal crystalline lens. So phakia is called normal crystalline lens because our lens contains these crystalline proteins. Okay. Now, these crystallines are of three types: alpha crystalline, beta crystalline, or gamma crystalline. Alpha, beta, gamma crystalline. Alpha crystallines, they are the largest crystallines in size, guys. Their function is that they are heat shock proteins. They are HSPs, heat shock proteins. So they function to prevent denaturation of other crystallines. Okay. I hope we are clear about this, everybody. Alpha crystallines, they are heat shock proteins. Heat can lead to denaturation. So if you want to remember it like this, heat can lead to denaturation. So because they are heat shock proteins, they are saving us from the denaturation. They are saving us from that shock. Okay. Beta crystallines form the major portion. That means they constitute almost 55% of the total proteins. Okay. Now, moving on to the water insoluble proteins, group 1, that is urea soluble. Some names of the proteins. So examples, everybody: vimentin, phylensin, phakenin. So these are just some names of these water insoluble, urea soluble proteins. They are cytoskeletal proteins. Cytoskeletal proteins. Basically, they are helping to form the structure, cytoskeletal. Yes. So their disruption leads to cataract formation. Because if they are disrupted, the structure is disrupted. Structure disruption can lead to opacity. Opacity, as we all know, is cataract. Okay. Now, the last group, guys, water insoluble as well as urea insoluble. The example in this is known as MIP26. MIP26, which is also known by another name, which I hope will bring clarity to you: aquaporin 0. Aquaporin 0. MIP26 is also known as aquaporin 0. As soon as I say the word aquaporin, you understand the function. Yes, aquaporins are water channels. So by moving the water in and out of the lens, what is this protein doing? It is helping to maintain the transparency of the lens. Okay, everybody? So help to maintain transparency of lens. I hope we are clear about the three groups of proteins, everybody. Number 1, water soluble, crystallines. Number 2, water insoluble, urea soluble, cytoskeletal proteins. Number 3, water insoluble as well as urea insoluble, MIP26 or aquaporin 0, responsible for maintenance of transparency of lens. Okay? Now, apart from the proteins just stated, everybody, the three groups of proteins, there is another group of proteins that we call as HMW proteins. HMW, or I can say high molecular weight proteins. High molecular weight proteins in lens. Now, these high molecular weight proteins are basically numbered HM1, HM2, HM3 and HM4. HM1, 2, 3 and 4. HM1 and HM2, they can be classified under water soluble proteins, but HM3 and HM4 are classified under water insoluble proteins. Okay? So if we merge the classification so as to say 1 and 2 become water soluble, 3 and 4 become water insoluble. The important point or the important question that comes from this had been asked in AIMS 2015, everybody, that HM3 and HM4 increase in concentration in cataract. That if cataract has formed, everybody, and if we measure the amount, then HM3 and HM4 concentrations would be increased in the cataractous lens. This was the question, everybody, which was asked in AIMS. Which of the following types of proteins increase in a cataractous lens? The options were HM1, 2, 3, 4, 1, 3, 2, 4, something like that. Okay? Now, please do remember, apart from this, that if they specifically ask you HM4, only HM4, increased concentration in nuclear cataract. So basically, if the examiners want to go one up on the question that they have already asked you, they had only asked in all types of cataract as a generalized statement. Now if they want to be specific, everybody, in nuclear cataract, only HM4 is increased, everybody. Okay? So please do remember this. There should be no confusion again about this, everybody. That's all about our simple topic, that is proteins in lens. Now, what are the antioxidant mechanisms in lens? Antioxidant mechanisms in lens. Okay? So that's another easy topic, easy question, guys. Again, fact-based. So there are basically 5 antioxidant mechanisms. The first one, all of us know, superoxide dismutase, SOD. Second is the enzyme catalase. Third, which is important, is glutathione reductase. Glutathione reductase. Fourth and fifth are 2 vitamins, vitamin C and vitamin E. Please remember, not vitamin A. Not vitamin A. So this is a question which you will encounter in your question banks or in your previous year questions, guys. That vitamin A otherwise is an antioxidant, yes. But for lens, vitamin A is not considered an antioxidant mechanism. So vitamin A, C, E are antioxidant, but A is not antioxidant for the lens. Lastly, everybody, low oxygen levels around lens. Low oxygen levels around the lens also contribute in its antioxidant mechanism. So what do I mean by this, everybody? See again the cut section. We know that the lens is avascular. Yes, avascular means no vessels. No vessels mean no blood means no oxygen. Yes? Similarly, we know that the vitreous is avascular. Because vitreous is avascular, again it does not have any oxygen. So neither does the vitreous have oxygen, nor does the lens have oxygen. So lens is basically cocooned, you can say, in an environment of low oxygenation. But if in case of a retinal disease, we need to do vitrectomy. Then this cocoon is lost. Yes, because the posterior surface, which was covered by another avascular, lacking in oxygen structure, that is vitreous, is now removed. Yes, so that is why we say in cases of vitrectomy, this low oxygen level is lost, which leads to increased incidence of cataract formation. Okay, everybody? Simple? Done? So that's one point. If you didn't know, please remember that after vitrectomy, the oxygen levels which are normally low will increase, and that increased oxygen levels may lead to formation of cataract. Simple topic, everybody. Antioxidant mechanisms in lens. Vitamin A is not an antioxidant. I need you to remember that. Then, next topic, everybody. There is something called as lens paradox. See, these are very simple, short topics or questions in themselves, you can say, everybody. Yes, this is your basic of lens. Lens paradox. What do you mean by lens paradox? That in old age or with increasing age, two processes occur in the lens. What are the two processes which occur, everybody? Number one, there is increased curvature of lens, and number two, there is decreased refractive index. Two things are occurring, everybody. Increased curvature, decreased refractive index. Increased curvature will lead to everybody more power in lens. I hope we remember this. The same fundamental is followed in accommodation, everybody. That when the curvature of the lens will increase, the power will increase. So with age, a slight increase in curvature is seen, so slight increase in power is seen. But there is decreased refractive index. Refractive index, if it decreases, the power of the lens will actually decrease. So there is less power in lens. Okay? So basically, they balance each other. And that is why there is a net effect of no increase or no decrease. And that is why, because there are two processes which are opposite to each other, this is known as a lens paradox. Continuing in the series of these basic topics in lens, our last topic is metabolism in lens. Now, metabolism means what? Utilization of the carbohydrate to generate energy. Carbohydrate means glucose. But the first question is, where does the glucose come inside the lens from? Lens is avascular. Avascular means no blood. No blood means no nutrients coming. Yes? So, glucose diffuses inside lens from aqueous, mainly aqueous, guys, but some little part also from the vitreous. Okay? So majority of it is coming from the aqueous, but some part of it is also coming from the posterior surface via the vitreous. After it has come into the lens, it is metabolized by various methods. So it is metabolized by mainly greater than 80% glucose gets metabolized by, should be a common sense question. It should be an aerobic process or an anaerobic process, guys. We have discussed that lens contains, or lens is cocooned in low levels of oxygen. Low levels of oxygen means it has to be anaerobic. So greater than 80% is by anaerobic glycolysis. So most common method of metabolism. Then around 15% goes through the Krebs cycle or HMP shunt. Okay, Krebs cycle or HMP shunt. HMP, biochemistry guys, hexose monophosphate pathway. Yes. Then the last remaining less than 5%, everybody, less than 5%, can be even just 1%, goes through the pathway that is of interest to us, sorbitol pathway. Sorbitol pathway. Now, what occurs in sorbitol pathway and why is it of interest to us? Let's try to understand. In sorbitol pathway, glucose directly gets converted into sorbitol, another sugar, via an enzyme. That is the first biochemistry question you can say that is asked to you. Which enzyme is responsible for the sorbitol pathway of metabolism? The answer is, everybody, aldose reductase enzyme. Aldose reductase enzyme. Now, what is the problem in this pathway? The problem is that sorbitol is forming. That is the problem. Sorbitol is a sugar which can not diffuse out of the lens. Okay? See, glucose has a two-way diffusion. It can come in, it can go out. But sorbitol, it is forming inside the lens and it cannot diffuse out at all. So basically, sorbitol accumulates in lens. It is a sugar, everybody. Try to understand. A sugar is accumulating in the lens. When a sugar will accumulate in the lens, what will occur, everybody? There will be increased osmotic pressure. Now, through basic physics and chemistry from school, we know that fluid flows from, everybody, areas of low osmotic pressure to high osmotic pressure. So basically now the lens will draw in the fluid. Okay, everybody? So fluid is drawn inside lens. My lens was transparent. My lens needs to be transparent. When it draws fluid, it becomes hazy, it becomes opaque. So this leads to opacification. And this opacification, everybody, all of us know, is known as cataract. So I hope you understand why I said that sorbitol pathway is of importance to us. Sorbitol pathway is of importance because we know that whenever sorbitol pathway will become active, cataract will be the end result. Am I clear, everybody? So sorbitol, number one enzyme is aldose reductase. Number two, it leads to cataract by the explained mechanism. But does it mean that all of us will have cataract due to sorbitol pathway? No. See, sorbitol pathway can be said to be a reserve pathway, which will become active only in cases of hyperglycemia. When the sugar load increases, when my anaerobic glycolysis is rate limited, Krebs and HMP, everything becomes rate limited. Yes? So, sorbitol pathway becomes active in which diseases? That's now the third question. So, sorbitol pathway is active in diseases like, number one, obviously, diabetes, hyperglycemia, also galactosemia. Okay, no confusion, everybody. So sorbitol pathway gets active in diseases like diabetes and galactosemia. So diabetic cataract or galactosemic cataract can be called as sorbitol pathway cataracts or sugar cataracts. Okay, this word is mentioned in some of the textbooks. sugar cataract. So I hope you understand by the whole name of the disease and the whole process why they are called as sugar cataracts. Done, guys? That's all about the methods of carbohydrate or glucose metabolism in the lens. There should be no confusion, everybody. Please focus on sorbitol pathway mainly. Now, just to end my metabolism topic or something related to metabolism, there has been a question previously which has been asked on transport of ascorbic acid in lens. Due to variability of answers, there have been some confusion over it. In my experience, students keep asking us this question over and over again. I will make it clear for once, everybody, that the transport of ascorbic acid or vitamin C in the lens is via sodium dependent transporter known as SVCT2. Okay, SVCT2. This is an active process. As simple as that, guys. It's a fact. Just remember this fact. Transport of ascorbic acid is done via sodium dependent transporter SVCT2, and obviously because it is sodium dependent, because it is being done with the help of a protein SVCT2 transporter, it is an active process. Done, guys? So that's my first part of lens being done for you, everybody. The first part of the lens, basically we have discussed not a disease, but just the basics of the lens. The first 11 points in terms of the anatomy, where we discussed the blood supply, nerve supply, the site, the structure, the sutures, and the Weigand's ligament and all that stuff. Then we did some simple topics like proteins in lens, metabolism in lens, lens paradox, and all the stuff, right?